Hi everyone, welcome to my channel. Learn Oral and Maxillofacial Surgery with Dr. Anuj. I am a maxillofacial surgeon and Indian board certified maxillofacial surgeon, PG guide and professor in Rural Dental College Loni, and I have my own clinical practice in Nasik, Maharashtra. Today, we'll be talking about a very important topic in the field of maxillofacial surgery, that is Ludwig's angina. Before we dive into details of the topic, let us try and understand the subheadings under which we are going to discuss this topic. So we will try and introduce ourselves to Ludwig's angina. We will learn what is the pathophysiology of the disease. We will understand the surgical anatomy of that region. What is the etiology of Ludwig's angina? We will see how it manifests itself clinically. How does the disease progresses if it is not treated on time? What is the most probable and most acceptable treatment of Ludwig's angina? And then we will just summarize and conclude. Now, Ludwig's angina is a serious and a potentially life-threatening cellulitis that involves the floor of the mouth and the neck. Okay, the disease was first described in 1836 by a German surgeon named Wilhelm Friedrich von Ludwig's. Okay, so the disease is named after this German surgeon, and it is serious and it is potentially life-threatening cellulitis of the floor of the mouth. Now, when I talk about cellulitis, you might feel what is cellulitis and how cellulitis is different from abscess. So what we need to understand is cellulitis is an acute condition. That is, it has developed in a shorter duration as opposed to an abscess, which is a chronic condition. Cellulitis, it is more painful and pain is more severe and generalized as opposed to abscess, which is more localized. Cellulitis by its nature involves a large surface area as opposed to an abscess, which is confined to a smaller area. Cellulitis has diffuse borders because it is aggressive, it is rapidly spreading, it has diffuse borders as compared to an abscess, which is well circumscribed and localized to a particular space. Cellulitis contains very minimal or no pus as opposed to an abscess cavity, which is full of pus. And the bacteria responsible for development of cellulitis are usually aerobic bacteria as opposed to an abscess, which is full of anaerobic bacteria. So that is the basic difference between a cellulitis and an abscess. And what everybody need to understand is that Ludwig's angina essentially is a type of cellulitis. It is not an abscess. Okay. Now, what are the spaces involved when we speak about Ludwig's angina? A very important thing for everyone to understand that Ludwig's angina is involvement of bilateral submandibular, bilateral sublingual, and submental spaces. Now, the most important word here is bilateral. If the disease is not involving bilateral submandibular and bilateral sublingual spaces, it is essentially not Ludwig's angina. Let me emphasize that again. If the disease is not involving bilateral submandibular and sublingual spaces, it is not Ludwig's angina. It is merely space abscess of that particular side. So it can be right side, it can be left side, but it cannot be Ludwig's angina. All right. Now, what is the pathophysiology of the disease? Okay, we've already discussed it is rapidly progressing disease. What we also need to understand is it is a polymicrobial cellulitis. Polymicrobial meaning multiple types of microorganisms are responsible for development of this disease. And this disease leads to life-threatening airway compromise. Now, the most of the morbidities and mortalities associated with Ludwig's angina are because of airway compromise that we will discuss subsequently. The most common organisms which are isolated from these infections, they include Streptococcus viridans and Staphylococcus aureus. Anaerobic organisms like Peptostreptococci, bacteroids, fusiform bacilli, and diphtheroids are responsible for development of this disease. And this polymicrobial nature of the disease is responsible for rapid spread and aggressive spread of the disease. Now, if I try to explain you how the disease progresses or how the disease starts, try and spend some time understanding this schematic diagram. This is a coronal section from the posterior region of maxilla and mandible. Now, what you need to understand is when the disease starts from a carious tooth, okay, suppose it's a carious first molar, mandibular. Now, when the disease starts from a carious molar, it spreads into the periapical area here. And from this periapical area, when the disease perforates the lingual cortical plate, okay, if the disease perforates the lingual cortical plate superior to the attachment of myloid muscle. See this red muscle, this is myloid muscle. So when the disease perforates superior to the myloid muscle, the disease spreads into sublingual space. Okay. And if the disease perforates inferior to the myloid muscle, the disease first will spread into the submandibular space. Okay. So it starts off as an abscess of the molar, reaches the periapical area. From periapical area, either it perforates the lingual cortical plate above the mylohyoid. In that case, it goes into the sublingual space, or it perforates below the mylohyoid. In that case, it spreads into the submandibular space. And from these spaces, the disease rapidly spreads to involve the rest of the spaces and manifest itself as classical Ludwig's angina. Okay. Now, the same thing that we have discussed in the previous slide. So, disease either starts off as a submandibular space infection, then it spreads into the sublingual space, in the midline, in the submental space, then it crosses to the opposite side and becomes classical Ludwig's angina. Okay. Now, try and understand this diagram. Okay. It's very important for you to know how the disease spread from one space to the other. Okay. Now you see this muscle here, this is the mylohyoid muscle, okay? And this structure that is, hugging the posterior part of mylohyoid is the submandibular gland. Now we need to know that submandibular gland has two components. One is the superficial lobe, other is the deep lobe. So the major part of the gland that lie inferior to the mylohyoid muscle is the superficial lobe. And the part that hooks around the mylohyoid muscle and goes into the floor of the mouth, this smaller part, that is the deep lobe of the submandibular gland. Now, when the disease starts in the sublingual space, it spreads around the deep lobe, follows the superficial lobe, and it enters into the submandibular space. And when it starts in the submandibular space, it goes in the same direction, but the opposite way. So it goes along the superficial lobe, follows the deep lobe, enters into the sublingual space, and it causes a sublingual abscess. Okay. So submandibular gland is very important pathway for spread of infection from sublingual space to the submandibular space or from submandibular space up into the sublingual space. All right. Now, what are the predisposing factors that might lead to development of Ludwig's angina? First and the most important factor is presence of dental caries. Then mandibular fractures which are not treated or which are infected. Third factor is uncontrolled diabetes. If patient is uncontrolled diabetic, their immunity goes down. They are more vulnerable for development of infection. A malnourished patient and patients who are chronic alcoholic, their immunity is compromised and they are vulnerable for development of dental infection, developing into space abscess or cellulitis more as opposed to normal healthy individual. And patients who are immune compromised, patients who have received organ transplantation, patients who are HIV positive, they are more prone to development of infections like Ludwig's angina. Other sources of infection include chladenitis, that is infection of submandibular gland or sublingual glands, peritonsillar abscess, which is also known as quinsy, infected mandibular fractures, trauma to the floor of the mouth or puncture wound in the floor of the mouth, Oral lacerations which have not received adequate treatment. Epiglottitis. Epiglottitis means inflammation or infection of epiglottis. An extremely rare cause of development of Ludwig's angina is tongue piercing. So primary infection from tongue can also cause development of Ludwig's angina. So these are some of the rare sources of infection, but the most common source is carious involvement of mandibular premolars and molars. Now let us try and understand how the disease manifests itself clinically. Now look at this picture. What we prominently notice is that there is a large swelling involving the submental region, swelling involving bilateral submandibular region, and there is swelling involving the upper part of the neck. So if I try to explain this swelling, it is a suprahyoid swelling that is lying above the level of hyoid bone. Suprahyoid swelling, which is large, the skin appears reddish in color, and because it is an infective process, automatically that area is going to be painful. It is going to be tender on palpation. Okay. So the most common symptoms associated with the disease are pain and swelling, which is very obvious, fever and malaise, which are usually associated with any disease causing inflammation. Trismus, because there is involvement of multiple spaces, there is involvement of multiple muscles of mastication. So automatically there is presence of trismus, that is difficulty in opening mouth. Drooling of saliva. Now the major problem with Ludwig's angina is patients have difficulty in swallowing, and because they find it difficult to swallow, all the saliva is getting accumulated in their mouth and they ultimately end up drooling that saliva out. There is fetid breath because it is infected, and there is painful neck movements. So these are the most common symptoms. Now, what are red flags? Red flags meaning some of the signs and symptoms which will warn the treating doctor that patient is already having an advanced stage of disease and he or she might require an immediate and aggressive treatment. So the red flags include tachypnea. Tachypnea meaning there is increase in the rate of respiration. Patient is trying to have short and fast breaths. Dyspnea meaning there is difficulty in breathing. Now, because patient is finding it difficult to breathe, they are trying to breathe a little faster in order to gain more oxygen. Dysphagia. Dysphagia means difficulty in swallowing. So it starts off with dysphagia to the solid food, eventually extending to dysphagia to liquid food. So in advanced stages, patients are not even able to swallow water, and that is how the entire situation becomes dangerous and life-threatening. There is drooling and there is respiratory distress. Now, why there is respiratory distress, that I'll explain it to you in the subsequent diagram. Okay. So clinically, a patient will have non-fluctuant suprahyoid board-like swelling in the neck. Now look at this picture. Okay. Large swelling suprahyoid, and when you touch it, it feels hard, just like a board. Okay. This swelling gives the neck a characteristic bull neck appearance, and there is elevation of tongue. Now, if I try to explain you this sagittal diagram, okay, you see this is the submandibular space that is filled with abscess. This is a sublingual space, again filled with an abscess fluid. And when there is collection in the submandibular and sublingual space, what happens? It pushes the tongue superiorly. See, this tongue is getting pushed superiorly. At the same time, the tongue is getting pushed posteriorly. Now, when the tongue is pushed superiorly, it presses against the palate. See, this is the palate. This is the soft palate. So the tongue is pressing against the palate and it causes difficulty in swallowing. And when the tongue is getting pushed superiorly and posteriorly, it pushes against the pharyngeal wall. It blocks the nasopharyngeal and oropharyngeal airway. And that is how patients find it difficult to breathe. So the major problem is difficulty in breathing, difficulty in swallowing. And what is responsible for that? Elevation of tongue and tongue pushing against the hard palate and tongue pushing against the wall of pharynx. Okay. Now, what are the potential pathways of spread of infection? Now, let us not discuss the upper half of the diagram. Let us focus ourselves on the lower half of the diagram. So, any disease that starts off as a disease in the mandibular periapical region, it either involves the submandibular space or a sublingual space. From there, the disease might spread to lateral pharyngeal spaces. From lateral pharyngeal spaces, it follows the carotid sheath, and following the carotid sheath, the disease might spread inferiorly or it might spread superiorly. If it follows the carotid sheath superiorly, it will enter into the cranium, and in the cranium, it can lead to two life-threatening situations. First is known as cavernous sinus thrombosis. Second is known as bacterial meningitis. If the same disease follow the carotid sheath and spreads inferiorly, the disease will spread into the mediastinum and it will cause mediastinitis, that is inflammation and infection of mediastinum. Okay. And along the carotid sheath, the disease can also spread into retropharyngeal spaces and prevertebral spaces, which is known as the dangerous space, and it can cause serious life-threatening complications. So that is the potential pathway of spread of infection starting from mandibular, molar and premolar teeth. Now the same thing we are trying to explain through the diagrams. Okay. Now a swelling involving the submandibular and sublingual spaces can spread inferiorly and involve the epiglottis, causing epiglottitis. The disease can spread along the carotid sheath, along the suprasternal spaces and reach the mediastinum, causing mediastinitis. The disease can spread into the parapharyngeal and lateropharyngeal spaces. It can cause something called as necrotizing fasciitis, and very rarely it can also lead to development of cavernous sinus thrombosis and bacterial meningitis. So these are the possible complications of Ludwig's angina. Now, the next thing which we need to know is what is the management. Okay. Now, we have already discussed airway compromise is the most common complication of Ludwig's angina, and that is the very reason why airway management is the most important treatment when we are discussing about treatment of Ludwig's angina. So, the first and the most important is airway management. Second is incision and drainage. We need to remove all the collection that is causing elevation of tongue, difficulty in swallowing, difficulty in breathing, and that can only be achieved by causing incision and drainage. Then we need to give adequate antibiotic therapy to the patient in order to minimize the spread of infection and in order to promote the recovery. And we need to maintain adequate nutritional balance to the patient, right? So how is the airway management done? Now remember, the easiest and the most important way by which adequate airway can be maintained is by putting in either a nasotracheal or a orotracheal tube. Now, when we are putting a nasotracheal or orotracheal tube, what we need to remember is that we need to do a laryngoscopy. Okay, lift the tongue, see the epiglottis, see the vocal cord, and then pass the tube into the trachea. Now we know that there is collection of pus in the sublingual space, and when we try to manipulate the tongue, we might cause rupture of the sublingual space. That rupture might cause spillage of pus into the oral cavity. Patient might end up swallowing that pus, and that swallowing can lead to development of aspiration pneumonia, which in itself can be a life-threatening situation. So putting an endotracheal tube orally or nasally with the laryngoscopy is associated with risk of aspiration pneumonia. And that is the reason why it is not the primary method of establishing the airway. Now, what is the better choice? Better choice is this. Okay, this is called as fiber optic intubation. Now, in fiber optic intubation, what is happening is a small camera is passed through the nose or through the mouth. Okay, we bypass all the structure, we enter the vocal cord, we enter the trachea, and that path that is created by the camera, a tube is passed along that camera and it is inserted into the trachea. So that is much more safer as compared to a orotracheal intubation or nasotracheal intubation because it completely eliminates the need for laryngoscopy and it minimizes the risk of causing rupture and aspirational pneumonia. Okay. If patient is in distress, okay, if it is an emergency and if you don't have an access to fiber optic intubation, then a quick surgical method of establishing an airway can be cricothyrotomy. Cricothyrotomy is a very simple procedure where a small opening is made in the cricothyroid membrane. A wide bore needle can be inserted through that, and that allows patient to breathe normal oxygen. Okay. But what you need to understand is cricothyrotomy, although it is an emergency procedure, but it is not a definite procedure. Cricothyrotomy will not give us a patent airway which can be relied upon for a longer duration. Okay. So it is short procedure, but it provides airway control for a shorter duration. A more definite procedure will be doing a tracheostomy. Tracheostomy is surgically creating an opening in the anterior wall of trachea so as to allow passage of tube, and through that tube patient can easily breathe bypassing the upper airway. So whatever obstruction is there above here, tongue pressing against the palate, tongue pressing against the pharyngeal wall, everything is bypassed and now patient is breathing through the tracheostomy. Okay. And that way you can have a better control of airway. And the advantage of tracheostomy is that tracheostomy tube can be kept in place for a very extended period in order to give us a safe and secure airway. By that time, we can easily manage all the infection that is developed superiorly. Okay. So after we have established adequate and safe airway, the next treatment is to start with the antimicrobial therapy. Okay. So we've already discussed in the previous slides that Ludwig's angina is a polymicrobial disease. And because it is a polymicrobial disease, it warrants the use of broad spectrum antibiotic. Okay. Broad spectrum bactericidal antibiotic. So as soon as the patient comes, we take care of the airway. We start with broad spectrum bactericidal antibiotic. We do the incision and drainage. When we do incision and drainage, we take the pus sample or whatever fluid is coming out of that drainage. We send it for pus culture and antibiotic sensitivity test, and then change our antibiotic regime as per the sensitivity report. But to start off with, it always should start with broad spectrum bactericidal antibiotics. Okay. Now, what are most common broad spectrum bactericidal antibiotic? They are ampicillin with sulbactam. If patient is allergic to ampicillin, then it can be clindamycin, gentamicin, combination of penicillin G with metronidazole. It can be combination of piperacillin with tazobactam, or it can be combination of ticarcillin with clavulanate. So these are the loading antimicrobial agent that should be used primarily in management of these patients. Okay. Now, a very important thing that everybody need to understand is when we are doing a definitive treatment, that is incision and drainage, the most important concept that everybody should understand is something called as Hilton's method of incision and drainage. Now, what is that method? If you understand this diagram, it's very easy to know. Okay. So this is the abscess cavity and these are multiple loculi of the abscess cavity. So we make a small incision. Okay. Then we take a blunt sinus forceps. We break the primary locule. Okay. We open up that space that causes drainage. At the same time, we must also break the multiple adjoining locules in order to establish drainage of all the cavity, all the locules. Okay. And once we've done that drainage, we insert a corrugated rubber drain, and that corrugated rubber drain should be safely sutured in place so that it stays there. It is not lost into the tissues. And this drain allows for persistent drainage of pus as long as the cavity is filled with one. Once the entire pus is over, there will be no discharge coming along the corrugated rubber drain, and that is the time when we should remove the drain. Okay. Now, when we speak about incision and drainage, we must also talk about what are the most common principles of incision and drainage. Now, these principles were described by Topazian and Goldberg. The first and the most important principle is that always make the incision in a healthy skin and the most dependent area, a gravity dependent area. Okay. Never make an incision in the skin which is most prominent. Okay. The thinnest possible area is where the thickness of the skin is minimum. And if we make an incision there, that will heal with very bad scarring and it will not give us an aesthetic outcome. So incision should be made in healthy skin and it should be made in most dependent area and it should not be the most prominent area. Second principle, always try to make an incision in the natural skin crease so that when it heals, it causes minimum possible scarring. Take the sinus forceps and dissect bluntly. Because we are entering into a deep space, there are important anatomical structures like glands, like blood vessels, like nerves, and we do not want to cause any inadvertent injury to them. So that is the reason why you should always dissect bluntly. After we have established the drainage, place the corrugated rubber drain and secure it in place. Now, how long the drain should remove or how long the drain should stay in place? There are two factors. One, if there is persistent discharge coming out of the abscess cavity, we should change the drain every 48 hours. The reason we should change the drain every 48 hours is because the drain itself can act as a foreign body. The drain itself can cause some infection in that wound. So that is the reason why it should be changed every 48 hours. Or if the discharge is minimal or there is no discharge, then we should remove the drain and allow the wound to heal by secondary intention. Okay. So these are the principles of incision and drainage that everybody should be aware of. Now look at this case, okay, a simple case that I am trying to explain to you. So this patient has large swelling in the submental space, large swelling in bilateral submandibular space. Now because there are multiple spaces involved here, automatically it requires multiple areas of incision and drainage, okay. So a submental space would require incision to be made in the submental region. Right submandibular and sublingual space would require incision to be made in the right submandibular region. And left submandibular sublingual space would require an incision to be made in the left submandibular regions. So that is how you have to have at least 3 incisions for successful treatment of Ludwig's angina. And the primary purpose of incision and drainage is to cause decompression. Release the pressure that is building up in the submandibular and sublingual region that is pushing the tongue against the palate and the pharyngeal wall. Once we release the pressure, that will minimize the spread, that will automatically relieve the patient and make their breathing and swallowing easier. Okay. Now, once we've drained it, we insert the corrugated rubber drain. You see those drains in place and they should be sutured so that they are stable in that area. They're not lost into the abscess cavity. So look at this case now. Okay. An elderly gentleman, large swelling in the submandibular, submental and opposite submandibular space. It gives that area characteristic board-like appearance, reddish in color, painful. Okay. If you look at this OPG, you will notice that there is a carious lower second molar and lower third molar. Second molar is associated with large periapical lesion. Now this periapical lesion probably would have drained either into submandibular or a sublingual space. And from there, it has rapidly spread to cause involvement of all the spaces leading to development of Ludwig's angina. So what we did, we made bilateral submandibular incision. We made a submental incision. We drained all the spaces. We inserted the corrugated rubber drain. We followed all the principles given by Topazian and Goldberg. And what outcome we have? See this. Okay. All the infection is settled down. Right side submandibular incision healed nicely. We can't even see where it is. Left side healed nicely. We can't see where the scar is. Submental area is still healing. You can see a small scar there, but that will also heal nicely. without leaving any unsightly scar to the patient. Okay. So if you do adequate treatment, if you do prompt treatment, then the recovery of patients is usually very good with minimum possible complications. Now, if I try to summarize the entire topic, okay, what I would like to stress upon are these four cardinal signs of Ludwig's angina. First is it is bilateral involvement of more than one deep spaces. Okay, if it is unilateral, it is not Ludwig's angina. If it is Ludwig's angina, it has to be bilateral. When we drain it, there is serosanguinous or putrid infiltration with little or no pus. We've already discussed the difference between cellulitis and abscess, and we know that if we are draining an abscess, we will get pus discharge. If we are draining a cellulitis, it will be serosanguinous with little or no pus. And we also know that Ludwig's angina is cellulitis and it is not an abscess. Ludwig's angina classically spreads along the facial planes and it does not spread along the lymphatics. And that is the reason why it involves the adjoining spaces. It doesn't skip one space and go to the other one. It usually involves the adjoining spaces. And there is involvement of connective tissue and fascia, but there is no involvement of glandular structure. Now, we've already seen that although the infection spread along the superficial and deep lobe of the submandibular gland, but it does not cause any direct involvement of gland itself. It only spreads to the connective tissue and fascia, but it doesn't involve the gland. So these are four cardinal signs of Ludwig's angina. So finally, to conclude, what everybody need to understand is Ludwig's angina is a life-threatening emergency. We've seen patients die of the disease if they are not treated on time. And because it is a life-threatening emergency, early diagnosis and early intervention is the most important aspect in successful management. Adequate airway management is essential to minimize the morbidity of the disease because most of the patients who succumb to Ludwig's angina, they die because of airway embarrassment. Prompt surgical intervention is necessary to achieve decompression of spaces and to minimize the further risk of spread of infection. We've already seen it can spread inferiorly, it can spread superiorly, and if it spreads, it can lead to lethal and life-threatening complications. And because it's a polymicrobial disease, broad spectrum antibiotics are primarily required for successful management of these patients. Okay, so I hope I am able to give you some understanding of the disease process. Okay, I hope that with this you will have better understanding of what Ludwig's angina is, how the disease spreads, what is the most appropriate treatment of Ludwig's angina. Okay, and if you have any queries, if you have any doubt, or if you have any suggestions to make about this video, you can feel free to get in touch with me. You can write a mail to me. You can get in, contact with me on my number. And it was a pleasure interacting with all of you. And I hope to see you in the next class where we discuss about one more important topic as far as the oral and maxillofacial surgery is concerned. Thank you and bye-bye.